We are now somewhere where we have a new collection of drugs called direct-acting antivirals, which are the polar opposite of what we used to have for treatment. These drugs are safe, they are easy to take, very few side effects, short courses, and I suppose the most important thing is for most people, they work. They're really effective for pretty much everybody. And so those changes that we've seen have let us start to think about how we give out Hep C treatment and where we can do that. And the first thing we did was look for pretty much barriers and enablers to this whole idea. So what's going to stop GPs doing it? And you mentioned capacity, which was a huge thing that came out of it, but what also might help at the moment. And those ideas, those barriers and enablers, they shaped the structure of this pathway. So however this pathway worked, we needed to make sure that the burden on GPs was reduced as much as possible. So for that reason, it's kind of designed as a treat and refer pathway. The GP initiates treatment, and really that's where their job ends. The other services pick up the patient then and do everything that they already do, but just do it in a slightly different order. The other big thing that we did in terms of alleviating that burden was moving the assessment of liver fibrosis to the very end of treatment. So traditionally, that's always been a big barrier. To be able to actually give some practical outcomes, we've got rid of one of those problems that you've been worried about, was a key enabler, but something a lot of people thought that's why this pathway would be really useful. It really feeds into that idea of being able to give holistic care for these people without not sending them to 30 other specialists, different people, which a lot of people, as we know, find really difficult engaging with people like that.